Hello. Hello, dear colleagues. Good morning, good afternoon, good evening, wherever you are. I am happy to welcome you to our newest webinar on vaccines and special risk groups, today on the topic of diabetes. I'm moderating the session. My name is Astrid Chock. I am the Director of Policy Care, a Swiss interprofessional nonprofit association. We do implementation projects on non-communicable diseases, and I am also working for the Swiss Society of Endocrinologists and Diabetologists, where I am coordinating some working groups. I am also an FIP lead for the development goal, working with others. And I would like to announce that FIP thanks Sanofi for supporting this online event through an unrestricted funds. I have some announcements to make. This webinar is being recorded and live streamed via YouTube. The recording will be available on our website on events.fip.org. You may ask your questions using the question box below the Q&A box provided. And you're also welcome to provide feedback to webinars@fip.org. I would also like to invite you to become a member of FIP, and you can register your membership on www.fip.org/membership registration. This webinar is being translated in French, and if you want to have to listen to the French translation, you can use the icon below. La traduction en français est disponible dans le Zoom et vous pouvez utiliser l'icône d'interprétation ici dessous. Vaccinations and diabetes, is there any action needed? WHO and the European Centre of Disease Control recommend an influenza vaccination rates of 75% and above for patients at risk. National reports, on the other hand, show decreasing vaccination rates. For example, in the UK, diabetes patients' vaccination rates, depending on the region, are between 48 and 52%. In Switzerland, Quality Care had a recent survey on NCD patients' vaccination rates, and they're with 37%. And we also conducted a project on diabetes in GP offices, and they're also same as for all the NCD patients, it's 36 to 37%. For the other vaccination rates around the world, you will hear later in this webinar. Today is World Diabetes Day, which makes sense that today we are talking about diabetes. I would like to inform you about the previous events in this series, the vaccines and special groups on cardiovascular disease. We already had vaccines and special risk groups on older adults and also with chronic respiratory diseases. So this is the fourth in this series. As I already told you, my name is Astrid Chock. I'm happy to welcome Marco Hohenbier and Sally Kavanagh, Irina Vlasenko, as well as Javier Jimenez Ramirez. Today's program, after my introduction, you will have an input presentation by Marco Hohenbier, and afterwards we will have a panel discussion where you can also pose all your questions and have your questions answered with all the speakers, with Irina, with Sally, Francisco, and Marco. And at the end, I will just make some closing remarks. The learning objectives at the end of the event, the participants should understand the most important vaccines for people living with diabetes. They should recognize the role of pharmacists in promoting vaccination to people living with diabetes, and they should be able to discuss strategies for pharmacists to support people living with diabetes with their vaccination needs. Now I am happy to introduce and welcome Marco Hohenbier. He's a medical doctor and in internal medicine and intensive care at the Sparne Gasthuis Haarlem, Hofdorp, and Erasmus Medical Center in Rotterdam. He has a PhD in virology, and he's also a member of the European Scientific Working Group on Influenza and the chair of the Influenza Diabetes Community. Marco, the floor is yours.
Thank you very much for this kind introduction, Astrid. And of course, thank you very much for the invitation. It's a subject I really like to talk about. I was instructed to talk slowly. That's something that's quite difficult for me, but I'm going to do my best here. So today I'd like to talk with you about vaccination needs and benefits for people living with diabetes. As been said, most of my work is now currently on the intensive care as a clinician, but part of my time I spent as the chair on the influenza and diabetes community, which is an initiative partly also from the European Scientific Working Group on influenza. And much of the data and much of the stuff I'm going to discuss with you today comes from the field of influenza. So that's also the reason why a couple of years before COVID, we started this influenza and diabetes community. Because what we wanted to do was increase vaccination rates, improve prevention in persons living with diabetes with a translational approach, so that there would be clinicians, pharmacists, but also people from the patient community, basic scientists, and all together look on a way to improve vaccination rates and improve prevention in persons living with diabetes. So why? Well, that's what I'd like to discuss with you in the following 20 minutes. First, take a look at this very pretty, in my opinion, electron microscopy picture of the influenza virus. So to quickly remind you, influenza virus, as we look at it in a more digital way, so not only on electron microscopy, it's a respiratory virus, of course, with a combination of proteins on its surface, so the hemagglutinin and the neuraminidase makes it able to attach to a cell and enter a cell, but small changes in these two proteins can actually make this virus infect us year in and year out. And when there's a complete new combination of these proteins, a so-called antigenic shift, then what you get is a lower respiratory tract infection without any pre-existing immunity. What we all learned from the COVID-19 pandemic is what happens when there is a respiratory tract infection without pre-existing immunity, that the results can be really, really bad for the whole community. But what about influenza and diabetes per se? Well, there have been publications regarding influenza and diabetes already from the 1950s, but we see a peak increase during the pandemic. And this has to do with the fact that, again, we got confronted by the fact that persons living with diabetes had a much higher chance of a severe respiratory infection. So also because of COVID, people started to look again into the mechanism behind this increased risk of disease severity in persons living with diabetes and respiratory tract infections. So what about diabetes? Just a short update for today's panel. So this is a highly heterogeneous disease. It's influenced by both genetic, epigenetic, genetic, behavioral, and environmental factors. And easily speaking, the disease ranges all from not being able to make any insulin, so no insulin production, either because of an autoimmune disease where you lost the cells that produce your insulin, or you lost your insulin production capacity due to recurrent infections or surgery, that your pancreas is no longer there, up to the way that insulin levels are quite normal, but your cells do no longer respond to insulin. So this type 2 diabetes, and especially this type 2 diabetes, which has a little bit more of effects from genetic factors and environmental factors, and they're also more prevalent in specific subgroups. If we look at this key fact slide, I think most important here is that diabetes is a huge problem. 10% of global health expenditure is spent on diabetes. 1 in 5 people with diabetes are elderly. This is, again, especially this type 2 diabetes. And also 3 in 4 people with diabetes live in low and middle income countries. You can imagine that also standard of care differs there a bit, and that the problems can be very high if factors deregulate your diabetes. So what about diabetes and influenza? And why are we actually discussing this? And why are we having this panel discussion on World Diabetes Day? Well, I think the first most important study that really showed this clear association comes from around 2009, published in the American Journal of Public Health. And it was actually a very interesting study where they looked at death certificates for a long period of time, and they analyzed these death certificates. And what they actually saw is when the cause of death was written as pneumonia or influenza or a respiratory infection, chances were way higher that the person on the death certificate was also someone that suffered from diabetes. So this was the first clear and I think very elegant study that showed a correlation between the percentage of persons living with diabetes and their more severe clinical course of infection after respiratory disease. And if we summarize a lot of data, because we only have 20 minutes, having influenza and diabetes triples the risk of you ending up in the hospital. It also quadruples when you are in the hospital that you end up in intensive care or mechanical ventilation compared to persons in the hospital without diabetes. And of course, these are rough estimates, depends a bit which study you take, but this is on average. Also, it doubles your risk of a secondary bacterial pneumonia after your influenza virus infection, again in persons living with diabetes compared to controls. And roughly speaking, and this risk it goes up from 1.2 to almost 5 times, but you have about a double the chance of actual mortality after influenza virus infection if you also have diabetes. Again, why is this the case? Is it simply fitness, or are there more specific mechanisms? Well, first you could argue that this is the case for any pathogen, because there's a common perception which associates diabetes with a general increased susceptibility to infectious diseases. This has to do probably with a changed innate immune system or a pro-inflammatory state. There's a higher infection-related mortality and morbidity rates in persons living with diabetes than in non-diabetic patients. And this is also very well studied in tuberculosis. But the actual reason for increased susceptibility to infectious diseases is poorly understood. Of course, first, hyperglycemia itself negatively affects outcomes during infection. And for my line of work, it's also in the intensive care that if your glucose levels are way higher, but more specifically, if they change a lot, the risk of mortality is a way higher. And this has to do with both micro and macrovascular complications due to those glucose regulations and a direct impact on both the innate and the humoral immunity and the immune response. So if we only look at glucose, is glucose then the bad one? Well, we do know that hyperglycemia is related with a worse outcome in both bacterial and viral infections. And there's an interesting prospective study from 2016, which showed a nonlinear association with your HbA1c, which is simply said your average glucose level for the past 3 months, directly with influenza mortality. So the risk of more severe disease is already increased by having diabetes, but if your diabetes is also not that well regulated, those chances increase even more. Also, you could argue that actually obesity is the problem, because we do know that obesity is a risk factor for many complications in many infectious diseases, and obesity is also a huge problem worldwide. So in 2014, it was already 1 in 3 overweight and 1 in 10 obese, but these numbers only increased. And what do we know regarding obesity? Well, you do have an increased risk of death upon seasonal influenza, but also your mechanical ventilation can be way more complicated due to the increased mass or the increased abdominal pressures due to the obesity. So it's an increased risk of death, but it's also significantly associated with hospital and intensive care unit admission and the need for ventilatory support. If we then look at animal models, because of course epidemiological studies are always suffer a bit from bias, especially in intensive care medicine or in severe infectious disease research. But in animal models, we actually saw that mortality upon seasonal influenza virus was increased in a rodent model or a mouse model of diet-induced obesity. So mice that were fed with a high-fat diet and they get mouse-adapted influenza, they had a higher chance of actual dying due to the infection compared to those that were fed a normal disease. Okay, if we then continue, could it be that there's a focus on other complications which are already increased in persons living with diabetes? For instance, cardiovascular complications are very well known in the diabetes community. It's one of the #1 eventual reasons of mortality in persons living with diabetes. And we also know that there's an increased incidence of acute myocardial infarction after respiratory infection. And this incidence is highest during flu season. Also, there is a consistent association between acute myocardial infarction and influenza activity. What I'm trying to say here is that in seasons where influenza activity is higher, the strain circulating could be more virulent, that there's also an increase in the number of acute myocardial infarction. Subsequently, during the H1N1 pandemic, we saw lots of vascular complications. And this is something we also saw in a comparable virus, but even worse, because during the COVID-19 pandemic, without any pre-existing immunity, we saw many coagulopathy complications during or after infection. There's also some interventional data, the Fluvax and Flucat, very famous randomized studies in persons with a high chance of cardiovascular disease. And when they were vaccinated, the risk in that season for actually getting a myocardial infarction was lowered. So vaccination prevented myocardial infarction. And here I'm talking again about specific influenza vaccination. This was later also confirmed in a meta-analysis of 5 trials. So just vaccinate. Should we just vaccinate? And this is all the debate we're actually discussing. Well, vaccination, of course, is a challenging thing itself in influenza. We're discussing shelf life. We're having problems with the strains we select, differences between the Northern Hemisphere and the Southern Hemisphere, influenza seasonality. And of course, again, in a risk group, in a specific risk group, you also have different responses towards vaccination. So challenges here, people of higher age, they actually respond differently to vaccination. They have some kind of lower tumoral response. Diabetes itself, because already from 1987, we know that there's a reduced humoral and cellular response, shelf life and timing, and also something, and I think this is very interesting, and events like today could help there, that knowledge and attitude towards vaccination, but also towards the fact that you belong to a chronic disease, could be one of the biggest challenges. Of course, for every challenge, there could be a solution. There have been interesting studies with high dose, other adjuvants, other vaccinations, combined vaccinations, and so on. So how is the coverage then of influenza vaccination, diabetes mellitus? We already, in the introduction, we already saw some interesting numbers. Well, we see that it's actually quite low. And in the EU member states, we actually wanted to have a target vaccination rate of 75% in risk groups, and only Northern Ireland in one season reached that numbers. And the interesting part here, that the main reason for not getting your flu shot when belonging to the risk group of persons living with diabetes was a fear of adverse reaction, but also risk group awareness, forgetting that you belong to a risk group. And I think this is something that can be vital in increasing vaccination coverage rates, but it's actually education, not only of the patient, but also of the healthcare workers. So what about COVID-19? And just briefly touch upon COVID-19 and to remain within time. There's some many publications on COVID-19 and diabetes, because as we all know, I think every researcher and every clinician became a COVID researcher or a COVID clinician during the pandemic. So many good reviews here, and only some very interesting physiologic studies. But these 2 papers I would like to advise you to actually read. What we saw is that so the COVID-19 and diabetes, the why, the what, and the how, and also the past, the present, and the future. But it depends a bit on which area of the world you're looking, but almost every epidemiological study on COVID-19 and diabetes ranked diabetes as the #1, #2, or #3 risk factor for complicated influenza. Why is this? Well, I think this is something that can be, that you can actually change the SARS-CoV-2 virus over here with any virus, but it depends a bit on which tissue is infected. But you get an inflammatory response. This can be somehow hampered in diabetes. There are some good animal models that showed that the first innate immune response is lower, meaning that peak viremia will be higher, and peak viremia, so the peak number of viruses in the circulation, is especially in COVID-19 associated with more severe disease. But also during early infection, you'll get a deregulation of your glucose regulation. So you'll see an increased insulin resistance, you see quickly changing glucose levels, and this will actually you get like a snowball effect. Anyhow, the infection will be more severe, but also your underlying chronic disease will be more hard to manage. So it's again an innate and a humoral system discussion. Your baseline cytokine levels seem to be higher, especially in not well-regulated diabetes and in obesity. So you already are a little bit more pro-inflammatory. Hyperglycemias of instance, but also airway secretion, because there are studies showing that quickly changing glucose levels will actually change your airway secretion and maybe thereby facilitating the chance of the virus moving to the lower respiratory tract. So upper respiratory tract infection might not even be a big problem, but it's the virus that goes down in the lungs without your proper immune response where you have a problem. So is it again viral load, the big player here? Because what we knew from the very first part of the pandemic is that patients that were inoculated with a high dose, also anesthetists, which did the first intubations without, which were very close to the patient, had a way higher mortality than low viral loads. Also what we saw in the difference between Alpha, Delta, and Omicron. So management, vaccinate and understand your humoral response. And I've got one more interesting picture for that, but also prepare yourself that treatment of severe COVID-19 will make your diabetes control worse, because we do know that corticosteroids are like the #1 reason for glucose deregulations, but there's no reason to withdraw corticosteroids in diabetes. Just prepare and make sure that glucose management will be optimized. One paper, which I think is very interesting, it's only a couple of weeks old, from Lee and colleagues in Frontiers 2020, and they looked at inactivated COVID and the mRNA vaccination in type 2 diabetes in healthy controls. And there are some very interesting pictures over here, but I think the most important message from this publication actually is what you see in the lower part of this figure, and that's after the first dose of both your mRNA and your inactivated COVID vaccination, that especially the cytotoxic and the CD4 well response will be hampered in the diabetes patients, but after their booster shot, this will reach the same to the control population. So the booster shot here is even more important in the risk group compared to the healthy controls. So infection in people living with diabetes should be prevented, not only because they have a higher chance of developing severe disease, but which specific vaccine should be used. So what you actually want to do as a physician or as any healthcare provider with patients in your practice with diabetes is that they do not get sick at all, because when they get sick, the diabetes will become a big problem. And I think this is something that should be discussed. And here also education plays a very, very important role. You need to convince the person sitting in front of you that even though for years he is going steady now, that the reason for years that he's going steady, that is the fact that he did not get a severe infection. And preventing that infection has hardly any side effects, hardly any negativities and negative points, and should really be of great importance. I think from immunize.org, and it's also in the FIP documents, I think this is an amazing table summarizing which vaccination should be considered and which really should be administered. And again, I think for respiratory tract infection, this is most important. Now we're talking COVID-19, influenza, but definitely also pneumococcal vaccination. And then the other ones you could actually discuss for specific cases. For instance, patients traveling, patients with lower extremity problems, for instance, diabetic feet. You could suggest to actually earlier use the tetanus boost of a higher chance of infection or not noticing the infection, and so on. But just take your time and read this table after this talk. I think this is a very interesting one, also with shortly summarized all the reasons why to administer a specific vaccine. So I would like to summarize now and also move over to the panel discussion to remain in time. I think the most important points I want you to remember after today is that there's a clear association between influenza severity and diabetes. And that's not only because persons living with diabetes have a disease and might be a little less fit, altered condition. There is a strong relation between influenza and especially also influenza virus and diabetes. There's also a clear association between COVID-19 severity and diabetes. And again, diabetes is ranked as the number 1, number 2, or number 3 risk factor for complicated COVID. Also, the novel diabetes is seen in COVID-19, and that mechanism is still under debate. It's like a type 1 kind of diabetes there, which is some kind of molecular mimicry, meaning that the antibodies against COVID could also attack the aisles of Langerhans in the pancreas. But I think this is a very, very rare complication, which we only witness now. And I think it's good to keep in mind that we only witness now because so many people were infected, because it was a true pandemic. And then the slightest and very, very small numbers, of course, increase. So COVID-19 treatment might promote hyperglycemic deregulation, and I think here there's no reason to withdraw corticosteroid treatment, but prepare yourself, and also be focused on this. So not only due to fitness, but most likely there are virus-specific factors. Vaccination is effective and safe, also in risk groups, but then again, booster vaccination or double dosing might be necessary. Appropriate timing is essential. And in the future, and I think this is currently also a WHO recommendation, and I think this is something we're going to do for chronic seasonality vaccination here, so for the coming years, is that you could actually co-administer your COVID-19, your SARS-CoV-2 vaccine, and your influenza vaccine. That might even be feasible and currently advised. And it's not a good idea to separate them and have like a week or 2 in between. So then it's better to take 2 jabs at once. So I would really like to thank you for your attention here, and I think all questions can go to the V&A or to the panel discussion. But I would like to give back the floor to our chair, our moderator of today.
Thank you, Marco, for this very interesting introduction. And I would like to now introduce all the other panel members. I would like to introduce Sally Kavanagh. She is a senior lecturer at the University of Huddersfield and leads the independent prescribing for pharmacist certificate and provides specialists diabetes teaching across the courses for the MPharm and Master of Science. She does this in conjunction with her role as an advanced clinical pharmacist at the Sheffield Teaching Hospital, NHSFT. She has an extensive portfolio in the field of diabetes, including being a member of the UK CPA Diabetes and Endocrinology Committee, and she is supporting the development and delivery of diabetes learning modules and the creation of an integrated care and competency framework for pharmacists in diabetes. She actively contributes to the academic literature for diabetes, including peer-reviewed journal articles and textbook publications relating to the role of pharmacists in diabetes care and insulin safety strategy. She's also a member of the NICE committee reviewing the suite of the diabetes guidelines. Welcome, Sally.
Hello, thank you for that fantastic introduction.
And I would also like to introduce Irina Vlasenko. She is the Vice President of the International Diabetes Federation. She is also a member of the European Medicines Agency, the EMA, working party with patients and consumers. She's also a representative of the steering group of the European Network of Centers for Pharmacoepidemiology and Pharmacovigilance. She's responsible scientific editor of the Ukrainian Pharmaceutical Journal. And Dr. Irina Vlasenko, she's an international expert in diabetes and takes part in the development of regulatory documents, medical standards, and others on the national and international level. She participated in many meetings with governments and other key stakeholders and attended many international congresses with a view to raising the awareness of diabetes and affecting policy changes. Welcome, Irina. And I would also like to introduce now my colleague, Francisco Javier Jimenez Ramirez. He's a professor and a pharmacist, and he is from Puerto Rico School of Pharmacy. In January, he began his professional career at the University UPR School of Pharmacy Department of Pharmacy Practice in San Juan, Puerto Rico. And he acquired his certification as a diabetes care and education specialist, the CDCES, and became a board certified pharmacotherapy specialist. His main focus and experiences have been related to community pharmacy services, especially for underserved populations, diabetes care and education, immunization, research and postgraduate training. Through the UPR community-based pharmacy residency program, which he started in 2012 in collaboration with 4 other pharmacies. And since 2016, he's been training and supporting community pharmacists and doctors of pharmacy candidates to provide and enhance the immunization service at the community pharmacy. He's also integrated in the UPR Medical Sciences Campus COVID vaccination clinic. Welcome, Francisco. I would like to invite all our listeners to write down all your questions for the panel discussion. I would also, just because we are having a live translation, I would like to give our translator a couple of minutes break, and I propose to have like maybe 2 minutes break so Mireille can take a drink and have some breathers. Please write all your questions in the Q&A box, and then we can also address them during the panel discussion. And in the meantime, I would like to ask our panel members to open their videos, and we can then start with the panel discussion in 2 minutes. So could I invite all the panel members to turn on their videos, and we can start with our discussion. I have one first question. And what is your perspective on the current uptake of the recommended vaccines in the special risk group? Marco, you showed the vaccination uptake is very low with influenza. What about other recommended vaccines?
Yeah, so thank you for this question. So overall, vaccine uptake is too low. And in the beginning, COVID-19 pandemic helped a bit because everybody was again remembered of the fact of the need of vaccination and especially the COVID vaccination. But after 2 years of COVID, you saw that people were getting increasingly tired of vaccinations. And one of my PhD students did a study of vaccination attitude in risk groups. And her conclusion was mainly that the fact that they forgot that they were not part of a risk group anymore, but also the healthcare professional that did no longer offer the vaccination. And I think so rates are way too low now, and I think we need to think. I think that FIP there is doing a great job. We need to rethink of how we're going to do this, because the general practitioner or the internal medicine specialist who has 8 to 9 minutes to talk to his patient is not going to add the vaccination in there, especially not if he also has to jab the shot in. So I think that's where the key is. It's in education, but also some kind of everybody accepting that we need to change roles a bit there.
Thank you. Francisco, what would you say? What is your perspective from your experience?
Thank you. I agree. I agree. I will add that providers understand the recommendations, but they are not promoting the recommendations as we should. Also, in the barriers section, I will provide you more details. And the patients don't understand the recommendations. So we need to be more proactive as a healthcare provider. Pharmacists have a huge opportunity because have a huge access to the population many times during the week, during the month, to promote vaccination and educate the patients. So we need to be more proactive to increase those vaccination rates, especially in the underserved population.
Sally?
Hello, yeah, we've also in the UK got a similar problem where vaccination rates are not close to what we'd anticipate. So in the diabetes population, generally, whether it be flu or COVID, it's around 50% uptake. But when you look at that data, that 50% is actually really widely distributed with some sectors of the population. So the white, wealthier population are generally accessing the vaccines and are getting the healthcare that they need. But there are very definite data that sort of the Black and Caribbean communities are not accessing the healthcare. And so actually it's our really at-risk population that are the people that are not accessing the vaccinations. So I think as pharmacists in those communities, there's some real opportunity around support and education and connecting with the community there to be able to improve vaccination uptake. But that's, and looking at the UK, that's our data at the moment, and that's the issues we're facing.
Irina, what do you say?
Thank you. I think, of course, it's not only patient, I think, know about vaccination, but also healthcare provider, and this it's super idea. Use our pharmacists, because from the strong opinion, pharmacists is not used enough because we are educated, we are very close with patient, and I try to promote this and as many pharmacists. But what I see that it's not connection with doctor. It's they reject us and also our help. This is one thing. Another, if we invite our pharmacists, of course it's great if it's enthusiasm, but as you say, as Marco said, they have not time for explanation. Even doctors have not. How we can, I all the time thinking about practical things, how we can implement them. I think, first of all, it's a lot of articles show cost benefit from vaccination. And this is main point. who pay for this? For our government must be interesting. Healthcare system must be interesting, pay less. And this may be some program with include pharmacists. With pharmacists will be motivated to do these services. We cannot say that, oh, please only spread information. It will not happen. And also, I recognize now that not too much good educational material for patient. So they have a lot of myths, scare something, and they have not answer. And what I find one article that patient with type 1 diabetes is very trust some recommendations from diabetic center or even vaccination in diabetes center, where maybe we can use this also. What I can add. Thank you.
Thank you for this overview, because like it also reflects we in Switzerland, I mean, Quality Care, we made a survey on the vaccination uptake of the healthcare workers. And in 2016, it was 40%. We asked GPs, we asked pharmacists, medical assistants, nurses, and pharmacy technicians. And now in 21, we got an increase to 60%. That's probably because of the pandemic. But what we also saw now is that those who were vaccinated themselves, they always recommended vaccination, and those who were not vaccinated themselves, they recommended it in certain situations. And also those who are educated in vaccinating or who are in training to be vaccinated, they also recommended it. So this is like something what you all actually said, we have to invest in education. We have to not only focus on the patient, but also we as healthcare professionals, we have a very important role to promote vaccination because the patient, they trust their healthcare provider. So thank you for this. I would also come to another question, is like, what do you think are the main barriers for increasing the vaccine uptake in this group for the recommended vaccines and the vaccine hesitancy? Or do you see a vaccine hesitancy? Maybe I will start with Francisco.
There is hesitancy among the population, because the main reason is that they believe that the vaccines is going to cause the infectious disease, when we all know as healthcare providers that is a myth. But many people still believing that there is a problem with the vaccine that is going to cause the disease, and that's one of the huge barriers that we need to work on. So education is very important, and promotion of the vaccines, and talking not just about the benefits of the vaccines, but also about the safety of the vaccines, to be objective with the patient and keep the trust that the population has on us, not just the physician, the nurse, the pharmacist, and all healthcare providers in general.
Marco, what do you say?
Yeah, so in line with Francisco, I think he's raising a very valid point here. And I think that so hesitancy is a thing, but it's also accessibility. And so there are some good educational leaflets there, for instance, for risk groups and for healthcare professionals, but you need to get them there. So I think it's not only accessibility to the vaccine, but also accessibility to the information. And in your question, you already raised a very important point there, that I think it's the short moment with a healthcare provider and a patient one-on-one, which can be so more efficient than millions spent on campaigns, because it's that short realization that it's the healthcare provider you trust, suggesting you that confirming to you that it's actually you that's in the risk group and you that needs that vaccine. If that can be combined with direct accessibility to the vaccine and maybe also administration, I think then rates would really get up. But I think there are now too many barriers either to get the vaccine or to get the information, and then the realization that you are the one that needs to be vaccinated.
Mhm. Sally?
Thinking about sort of the population of patients I see, one of the barriers is it's just another thing that they need to do. It's somewhere else they need to go. It's another appointment they need to do, and they're not identifying the value of it for them as an individual. So I think one of the things when you're looking at the barriers, and some of the really interesting papers have shown, is it's things where it brings it to your community and into your setting. The people around you are aware of the importance of it. That's where the value of people uptaking vaccines has improved. So when people believe it is relevant to them, as Marco was saying, that it is about them, that's where it's important. And I think that's where community pharmacists have played a really important part, because they're the people that have that contact, that relationship where they identify you by name and they're in your hometown and they're in your locality. So it does feel more personal. And I think that's one of the ways that we are overcoming barriers is in that context, rather than the national and the media campaigns. It is about that local to you and who you are within your community, that it's starting to make the connection. And I think tapping into that resource is how we can make a difference to vaccine uptake.
Couldn't agree more there. Perfectly summarized.
Irina, what's your...
Yeah, I absolutely agree with my colleagues, and it's really say about local communication. I think it's not enough be super professional in medicine or pharmacy. It's not enough. It's problem communication between doctor, pharmacist, and patient is big issue. And I find one clinician vaccine safety resource guide optimizing prevention of vaccine-preventable disease across the lifespan. They provide a 5-step strategy to work with vaccine hesitant patients. It's establish empathy and credibility, briefly address specific concern, if any, pivot to disease risk, convey vaccine effectiveness, and give a strong and personalized recommendation. This is, I think, that our doctor is very have big authority for our patient, and this is we must use this. More patient, not could you have, you have benefit from this, and there's more strong. If you sure, patient also sure that it's recommended, strong recommended. Thank you.
I have in my head last year, there was the National Vaccination Conference in Switzerland, and there was a doctor from the UK, and he said that his patients, 96% of his diabetes patients were vaccinated, but he has a big poster in his office, and when he's talking to the patient, he will be, they would see it, the patients, this poster, and it says like, I'm vaccinated, are you? And he would always, like, while talking, he would look at the poster so that patient would also look at the poster. And that's how, just like by a picture, they would get vaccinated. Oh yes, okay, I will vaccinate you right now. So I think like small things, and it's also this, what you all said, like the local is much more efficient than if you have a national campaign, and people, it's too much. There's so many national campaigns that people just don't look at it, I guess, that much. And they trust their healthcare providers.
Absolutely great example. I will use this.
Yeah, that's stuck to my head. So what are your thoughts? I mean, Marco mentioned this already, the thoughts about co-administration as a strategy to improve the uptake. Do you think that would help? I don't know, Sally?
I'm a big advocate for the co-administration of the vaccines. As somebody who works, and at work it's convenient for me, so why wouldn't it be convenient for the people that we're seeing? As I've already mentioned, these are people with complex diseases where they've got to go to lots of different places for lots of different appointments. Anything we can do that supports them having it in one setting as a single appointment, I think is really valuable. And in the UK, the way our systems are modelled, our community pharmacists can give the vaccines, and they can often give both vaccines in the same appointment. But it's still two separate processes. You know, they're paid for each thing that they do as separate appointments. But I think for the person receiving that care and receiving the vaccines, I think it's really valuable. So I'm a big advocate for it. And I think anything we can do to communicate the safety of doing that at once is really valuable. My partner gave a great example related to this of why it's safe. And it was saying essentially that our immune system is continuously fighting infections. It's what our immune system is there to do. So communicating it in lay language to people, to patients, that actually our immune system's designed to do this, and giving two vaccines at once is fine, I think is a big part of what we need to do to help people to consider that as an option, really.
Irina, what do you?
Pardon?
Irina, what are your thoughts about the co-administration as a strategy?
It's a difficult question for me because I'm absolutely theoretical, I support. But when I go back and stand next to a patient, and what I can do if something happens, like after this vaccination, what I must do, how I can support these people. This is, I think, main barrier, which it's not everybody want to do. But anyway, it's a lot of possibility and emergency and so on, but it must be only structure, very prepared for give to this responsibility, of course, educated without discussion, and how do this, it's without discussion, but also for response, suddenly something happens. This is must be protect also healthcare provider as pharmacist for this responsibility, only like this. But I know many pharmacists have already agree that give this, and they look wider, but not only the sale medicine. There's this big role of pharmacists. Thank you.
May I come back with something related to that? I think it's really important if we sort of look at what we do across healthcare as a whole. We willingly and happily vaccinate our children with multiple injections at once, and there's lots of experience in doing that. And I think we can then use that as a real sort of social thing with our patients, of saying, we've got lots of experience of multiple vaccinations at once, and although that you might have a reaction and we won't know which one it's to, the same could happen when we do things with the vaccinations we do for children, or when you're going on holiday and you have multiple vaccinations in that scenario. So I think although we'll never be able to definitely say it was this vaccine or this, I think we've got enough sort of experience on the whole subject to say, oh, I personally would say, but I feel comfortable to support this co-administration. And Marco is obviously the expert in this, so he can say otherwise, but that's sort of where my perspective would come from on the subject.
I agree with you there, Celine. I absolutely agree, and I think this is definitely where to focus.
So what is your take about, what do you say, like, would co-administration maybe help?
Yeah, I think co-administration would definitely in the short term help, because people are still more focused on the COVID vaccine, so it will increase the influenza uptake, definitely. But also, and I think Celine already mentioned that it's an other appointment for a patient, another time he has to go to his healthcare profession. So when he's there, he or she, and you get them to sit down and take their shots, I think it's best to combine them all. And it's not something that we're not used to, because when somebody goes traveling, we combine a lot of shots. Yellow fever, DTP, typhoid, it's all not a problem. But of course, when you're going to do it in a bigger population, and there's discussion, but I think definitely co-administration is something that needs to be, that will help for the barrier for the multiple appointments. And then of course there are many more barriers that need to be over one, but this is one that helps definitely a bit.
I think like the example where the travel is even more convincing than the children, because the children, their immune system is much stronger. But like everybody wants to travel, so everybody is willing to get vaccinated for travel, but not for regular to be healthy. Francisco, what do you say from your experience?
I promote co-administration of vaccines. The data in adults is limited. In kids, the majority of the studies are related to immunogenicity and not to side effects. But the limited studies that we have about side effects demonstrate that the co-administration do not increase the side effects. I'll give you an example. At the University of Puerto Rico Medical Science Campus Interprofessional COVID Vaccine Clinic, we used to administer just COVID vaccine. During the month of October, we start bringing a pharmacy who provide immunization services to administer other vaccines that we didn't have at the medical science campus. When we start evaluating the patients using the Puerto Rico electronic immunization system, which is the immunization record for the island, it's a medical record share between all immunization providers. We realized that many people are not vaccinated against other diseases like influenza, tetanus, diphtheria and pertussis, zoster, pneumococcal infections. And we start doing that service, and we already administered other vaccines besides COVID to at least 200 people. And we are talking about a medical institution, academic institution, health professionals in the majority of the cases, or people who are related to healthcare professionals. We identified many people who could benefit of other vaccines, and we are being successful right now. And during the month of December, we will continue doing the same. Those people maybe have other places to go, but they finish their shift work and they go home. They don't go to any other place to get vaccination. So we provided access to the vaccines, education, and we promoted the vaccines in the institution, and many people are getting vaccinated right now. So I promote co-administration of vaccines.
Okay, good. So I have one question here from the audience. Do you think structured brief interventions or motivational interviewing in healthcare settings could be an avenue to increase vaccination or vaccination awareness among people with diabetes?
And this, I think, an interesting approach. What we know from literature that interventions like these are most effective when they're combined by direct access to the shot. So this could be it, but after the interview, then also the vaccine should be there, and I think that's an interesting approach, and that's also where the possibilities lie when those logistics are not possible in standard daily care with a medical doctor. Then that should move to a place where this combination is possible.
Mm-hmm. Yes, because like after discussing and being motivated, if you say, okay, now you have to go to your doctor's office to get it, when the patient walks out from the pharmacy, for example, or from the wherever, it's finished. They forgot. They have to go shopping or something like this. So
you miss a couple of weeks, but again, for influenza with seasonality, your time frame for effective vaccination is short. It also really depends, of course, on the year and the strain selection. But I think targeted prevention here in a small group with direct access to the vaccine, that would be really efficient. Again, to the local community, as Celiane already suggested. This also has to do with the question from the audience, also with the number needed to treat to prevent one hospital admission. Now you could fill a whole webinar regarding that, because we know from the normal community that number needed to treat ranges from 12 to 35. So you could argue, so in a healthy population, 12 to 35 to prevent one hospital admission due to influenza. But if you move to a high risk population, you could say that this is way lower. But then again, we know that their response is also a little lower to the. So that this is in the diabetes community, this is not well studied. But yeah, you could think and argue here that would go towards the lower point of number needed to treat as in the healthy community. But then again, that will be also interesting to combine these local efforts and an increased vaccination rate also to improve our understanding of vaccine response in this risk group.
So what about everybody else about the short interventions? Do you have any experience in this? With short interventions that would increase the vaccination uptake?
Can I say something?
Irina?
Maybe, yes, of course, we can create something, but now I read something about modern technology, how they improve adherence to use medicine. Maybe we can use this for remind when they must go to, and they only send the message. It's very easy because it's risk group. It's not all nationality. This is risk groups. Every endocrinologist he will list everything, and this is a system registered. What you say, Francisco, that they make electronic system. I'm sure that for diabetes like first in like novator in many area, and then already have registered people with type 1 and have every information about them. And this may be easier, send only message, remind, or please be attention, are you vaccinated or not? It's very easy, but maybe it's work. And as you, I'm sure you read a lot of articles that small intervention like telephone calling and SMS message increase adherence for use medicine, and this case could be also. Thank you.
It's like I also see very often from experiences that the patient maybe not, the diabetes patient maybe not have an appointment with his doctor exactly in November, or in the, when do you have your next appointment? Oh, in March. Well, I guess this is a bit too late for a vaccination. So if he or she is in the pharmacist, then it would be important that also the pharmacist reacts and says, okay, but I can give it to you. Mm-hmm. And this, I think, is something also what needs to be increased, like the communication, the interprofessional collaboration in this sense. Because like if the pharmacist vaccinates the patient, the doctor should know that.
Indeed. Yep.
Absolutely. This is what we must improve.
And especially like with influenza vaccination, you don't really, I mean, I don't know, but in Switzerland, nobody ever records influenza vaccination in the vaccination card. We used to have an online tool, an online vaccination card, which was like everybody could access it, whom the patient allows the access. And there it doesn't matter because it's online, but unfortunately it was turned off because of data problems. But I think this would be something, because like the influenza vaccination, if the doctor administers it, he has it in his record, but the pharmacist doesn't know, and the patient does not really always remember. I don't know, Francisco, what's your experience in this with this?
Yeah, thank you. The strategy that I use is to intentionally structure, evaluate the patient as at every opportunity that I have. When I see the patient and I know that the patient can benefit of some vaccines, I go to the system and I tell the patient what they have already and what other vaccine the patient could benefit from. And I educate the patient about the benefits and the safety. And at the same time, I need to have some structure to administer the vaccine at that moment, because if not, I waste my time. So that for me is very important to have an intentional structure assessment at any time that we can do it possible and administer a vaccine. Also, one of the biggest problems that we have in Puerto Rico with the underserved population is that adults don't go to the traditional vaccination centers that kids or children are obligated to go when they go to school because the vaccines are required. But adults, they don't go to the vaccination centers. So in the pharmacy, we have a huge opportunity to capture that population. The problem is that the government have very limited vaccines available for the Medicaid patients who are beneficiaries of the government health insurance. And we do many campaigns and we don't have vaccines accessible for them. We have very limited amount of influenza vaccine, Tdap or tetanus, diphtheria, and pertussis, and one of the pneumococcal vaccines. That's all that we have for adults. We don't have zoster, we don't have BPH for this underserved population. So we make some efforts, but we don't have vaccines available for them. They can go to the pharmacy. We just have 3 pharmacies contracted by the government of Puerto Rico to administer vaccines to this population. So something that we can do to improve these services, to increase the pharmacies or other places where the patient can go to get the vaccine. The people who has private health insurances don't have that inconvenience. They can go to any pharmacist and get vaccinated.
Marco?
Yeah, so again, I agree. It depends a bit on local situations indeed and accessibility. But the only thing I'd like to repeat, because repeating something then it sticks best. But again, every effort by increasing information or increasing rate should be directly combined with accessibility to the vaccine. I think that's most important. And I like the suggestions made here by the whole panel and by you. Indeed, move it to the pharmacy, move it to where in seasonality a patient has a contact. So either indeed he goes when he picks up his pills during flu season, that he also has the possibility to directly be vaccinated. I think that's most effective.
Sally, you have any comment?
I think the value of motivation interviewing in all this and in diabetes in general is invaluable in that helping the person with diabetes to actually have ownership of their choices and their responsibilities in that. So I think the making every contact count as part of motivation interviewing is really invaluable. And as I've said before, I think having vaccines in community pharmacies is a brilliant step in improving that access. And as Marco's saying, talk to the person about their options and have it available to them should they choose to take it is key. I think one of the potential barriers coming back round to that sort of in the UK is we now have a lot of remote pharmacy and online pharmacy where patients are now not engaging with community pharmacy in the same way they historically did. So I think any sort of intervention that goes along with that service about come see us, say hello, talk to us about your medicines, talk to us about your vaccines is the next step we're going to have to move towards. I guess it's different barriers in different countries as well.
Difficulty there could also be that so when you increase communication via very modern media, or I also read a very interesting study in Australia where they combined flu shot with their Freestyle Libre, so their continuous glucose management and then advising of getting your vaccination. That's all really interesting, of course, and really next level, but you also increase the gap between the middle and lower income and where you do not have your continuous glucose management implemented.
Can I add something? I think we speak about the professional association, pharmacy and doctor, but we little forgot about not government patient organization. He can be very, very useful for this area. They have contact with patient more close than some pharmacy, and this is collaboration It's three of us, professional, and also without government, it's not possible. And this will be very, very useful, and also need explain even to not government organization, patient again, how it's important, and they have access, and this is they involve them in this promotion vaccination. I think it will be very, very helpful.
Yeah, there's some nice best case scenarios also from Diabetes UK. They really did some nice social media campaigns. But then again, even though the information is good and their access towards the patient population is way better than that from the healthcare provider, when it's not directly combined with a shot, then it's less effective.
I have one question regarding the remuneration of the pharmacist. If the pharmacist vaccinates the patient, do they get remunerated?
In the UK, we have quite a strong commissioned model for that. So if you are a pharmacist who's got the qualification to be a vaccinator and you are providing that service, yes, you get paid for every patient that you see and every patient that you vaccinate. So there is a financial motivator there for the community pharmacist to be supporting people to get vaccinated. There's a financial motivator there for them to engage with that service, to reach out to patients, whether that be, you know, everyone that comes in saying, are you vaccinated? Should we vaccinate you? Can we get you an appointment? So I think that model is in some ways improving access and improving vaccination levels, but that's not necessarily sustainable on a full-scale model or in all countries. So I think that's one of the potential issues.
Puerto Rico, the pharmacies is the very few services that the pharmacies receive reimbursement per professional service. We have increased the number of pharmacies that provide immunization services from 2 to 3 independent community pharmacy in 2012, 2013. And right now we have close to 200, between 175 and 200, plus the chain pharmacy that they provide immunization services since 2012 approximately.
So in Switzerland, the basic health insurance does not remunerate because like the law says everything has to be delegated by the doctor, which is paid by the basic health insurance. And the problem is like we also have a complementary health insurance, which would also pay for the vaccination, but like many diabetes patients, they don't have a complementary because this depends on the insurance if they are willing to insure that patient. So how could we promote still for the patients to get vaccinated in the pharmacy if they have to pay it themselves out of pocket? I mean, influenza vaccine is not that expensive, but also the work of the pharmacist also has to be remunerated, I think. But like, what is your idea, or what are your thoughts on this?
So,
Marco?
yeah, I was just also in the VNA there. An excellent study was just being typed there regarding a mega study on the nudges to encourage vaccination in pharmacies. So I was quickly reading upon that, but at the same time, so it's typed in the VNA. Maybe we can copy it to the chat, because I think that's an excellent study to discuss or to read for every participant after. The thing is, again, so also what Francisco said and what Irina was already touching upon. Of course, local authorities, local changes are essential there for its effect, and then there could be any difficulties in implementing a new strategy. But I think in the broader way, it's moving vaccination to a place where the vaccine is there, education is there, and information can be there. I think that is the way to move forward, and I think that this can be fast forward thanks to the COVID pandemic, because we learned so much in a short period of time, also about inefficacies in the way we're currently doing it. So I think that's something to keep in mind.
Irina, how do you think we could promote more in the pharmacy, especially in countries where the pharmacist is not remunerated? Because this is an incentive also for the pharmacist.
I don't believe that it's like if you say, please do something complementary. It may be 1-2 times, but if it's strategic, it must be according some rules, implement some national plan for this, and pharmacists must be involved, and then must be covered by, of course, if I'm sure that if a patient must pay for vaccination, it will be less. Because as Marco say, if it's not access, it's the low decrease. And from my side, it's must be national plan, include pharmacy. Like we know, many countries organized for prevention diabetes include pharmacists, and pharmacists have big role, but he was motivated and also get money for this, like part of salary. I don't know, it doesn't matter. But anyway, motivated, not you must do, but also motivated some also reimbursement or something like that. Because to be honest, I think that if it's must pay, they must pay, decrease patient vaccination. But pharmacists must be motivated. If you see, if even doctor have no time for explain how it's important, how it's for you important, but pharmacists maybe have less time, but he must be motivated. From my side, it's like national program, local program.
I have one question from the audience, which is like specially addressed to Irina. It's like, what are the initiatives and strategies set by the IDF to reduce the burden of diabetes in lower and middle income countries, and how can pharmacists be supported in combating this, or can support in combating this this burden of disease?
This is my subject. I can speak 1 hour, but please, I try. From my side, we have super big resource like education, people who know exactly, who can help patient, not necessarily make concurrent. It's only support prescription of doctor, explain how to use medicine, how is could be side effect, how, and also it's not about information, and also monitoring people, because they have chronic disease. They come to this pharmacy not every day, but every month minimum, and there you can check. It's good. What is your level, and also promotion, self control. And but for this we must also educate pharmacists. And I listen from our webinar also that many country involved pharmacists, like specific program, strategic through government strategic. And this is, I'm sure it's we have many evidence and cost effectiveness intervention pharmacists to diabetes care. This is my strong opinion. I'm very happy that we start collaborating with FIP.
I have like one last question to everybody. What action point would you prioritize to address the problem of suboptimal vaccination coverage in this population group? Just one. What would you prioritize, Marco?
I would go for targeted co-administration at your local pharmacy.
Mm-hmm. Francisco?
Limitation that we have is that we just can administer 3 vaccines with no prescription from the physician. One is influenza. I should say 4 now because COVID vaccine too. The other one is the Tdap, or tetanus, diphtheria, and pertussis, and the other one is a pneumococcal vaccine. For those, we don't need a prescription from the physicians. For the zoster vaccine and VPH and hepatitis vaccines, we need a prescription from the physician, and those are the lowest rates that we have. We could contribute more from the pharmacy if we can avoid the prescription required to administer those vaccines.
Sally?
I think if I could do a single intervention, it would be connecting my community pharmacists with community champions in our hard to reach populations, so we can get some advocacy within those groups to bring people in for those appointments.
Irina?
Say that it could be promotion through their pharmacist, maybe some leaflet. But what I want to underline, because I forgot to say this, that some crisis situation like in Ukraine now, only pharmacist affordable. It's main person because in war, many hospital closed, but pharmacists stay work. And this is, it's maybe only one person like healthcare professional can affordable. This is, it's not about vaccination, but this is also, it's very important, our role. And I think it's, we can do act in this.
Yes, I think this is also in Switzerland, you saw that also with the COVID vaccination, that in the end, actually many doctors also did not vaccinate against COVID, but a lot of pharmacists stepped up, and it was also a possibility for the pharmacists in Switzerland to show their competency. And even pharmacy technicians under the responsibility of a pharmacist were in some areas in Switzerland were allowed to vaccinate, which also gave them more competencies and more motivation to stay also in the job. Because I think, I don't know how it is in your countries, but we are losing more and more healthcare professionals. Nurses, the Nursing Association said like there are 300 nurses per month leaving their job. I don't know where this is leading to, but I think interprofessional collaboration will be more and more important, and we will be forced to work together, because the number of patients are growing and the number of healthcare professionals are decreasing. So there is no possibility to otherwise handle the burden of disease in any diseases, but also, especially also diabetes, the disease burden is also rising. Also in combination with obesity, of course. I have one question from Marco. Which vaccine is the most important? I mean, of course, you are the chair of the influenza diabetes, but what is your idea? Which is the most important? Where you could like which disease to prevent, or which vaccine could prevent the biggest burden of hospitalizations?
Yeah, so then I would opt for respiratory infections, and then it's hard to choose between flu, COVID, and pneumococcal. Depends a bit on the age of the patient and the site. And then with a little side note that, of course, hepatitis B vaccination is also very important in the endemic areas because of the use of needles and stuff. And it's a very, very efficient vaccine. Huh? So the thing with flu and COVID is that you need to re-administer. But with your hepatitis B series, your prevention could very well be lifelong. So that's investment-wise, maybe even better. With 3 shots, you make sure that someone doesn't get hepatitis B. But I think the biggest burden would be in respiratory infection.
Mm-hmm. Thank you. What's your take, Irina, from the position of the IDF?
I agree with Marco. This is very important. And then I only want to add that diabetes patient is very educated patient. It's very easy work with them if they understand. And I want to show one study that compare with obesity people and people with type 1 diabetes. And in these groups with type 1 diabetes, more vaccinated than only with obesity. This case, we have a good perspective for this. This is a cohort. We can work with them. It's they understand us more than another maybe patient. And this is it we must do. But I think we can achieve result if you like more practical. This we can achieve result in this area.
From your experience, do you see a difference between type 1 and type 2 diabetes in their vaccination uptake? Can you say so? Do you know?
I think it's for type 1 diabetes more people more. To be honest, I don't know about study but for type 2 it's more complicated. Anyway, more complicated to reach them, and and achieve this goal, like even follow for treatment. This is more difficult for type 2 diabetes. But and also, as I now know that now it's a lot of studies show that type 1 diabetes after the vaccination, it's only could be maximum 2 days with increase hyperglycemia. That's all. This is not need afraid this, and they know this. A lot of evidence about efficiency and safety. This is very important. I think we can. Type 2 diabetes is more common, but with them more difficult work, because this is also in population. Oh, type 2 diabetes is lifestyle. It's lifestyle. It's not lifestyle. It's also chronic disease. And from my side, it's even more complicated treatment than insulin. Insulin, if you find regime, it's absolutely great. But type 2 diabetes, I think doctor agree with me. It's not easy to find solution. Yes, we must make more work with this cohort. It will be more difficult.
So I think I have to wrap up because we have 2 more minutes left. I just like as a conclusion, I would say it's important. The accessibility to the vaccine and information is really important. We have to bring it to the community, and it's because it's about the people, about them. Local is better than a national campaign. The one-on-one, the education of the healthcare providers, and we also have to focus not only on the patients but also on the healthcare providers, because they have a very important role. And co-administration does not increase the side effects, and co-administration would promote a vaccination uptake. Short interventions are very good and important if the vaccination can be followed up right away, directly. And national plans should include pharmacists, definitely. So I would like to thank all the speakers for this very interesting webinar, for this very good discussions and very informative discussions. I would also like to thank the FIP staff and FIP that they provided this webinar. And I invite everybody else to check the events on FIP, upcoming events, fip.org. And I thank you for your attention. And remember, you can always listen to this webinar later on again in YouTube. And Thank you and goodbye, and have a nice day, nice evening, or good night. Bye-bye.
Thank you for moderator. Astrid.
You all have a nice day.
Have a nice day. Thank you. Very interesting.
Lovely to work with you all. Have a lovely rest of your day.
Yeah.
Bye-bye.
Bye bye.